when I think back over the years of how many famous people have come out of this institution and really led Canadian cardiology, put us on the world scene, it's quite incredible. And here we are 25 years later. So it's a pleasure to be here. Lots of new faces. I think I'm one of the older ones. And so, as I get older, I start running longer and longer distances, but eventually I think age catches up to you. So I've been asked this year to present something a little bit different, state-of-the-art percutaneous revascularization. And it's a really interesting and fun topic because this is what I'm really focusing on in a lot of my research. I'm going to just start with a general overview of where we are and where we're going with percutaneous revascularization. And really, we've come a long way. 1970s, we were doing POBA. Just getting the artery open was important. And then we had the bare metal stents come along. And then in the mid-1990s, we started using drug-eluting stents, which really took off in the early 2000 area. And that solved the whole issue of restenosis, and we thought we were done. But then there were more problems that occurred, and now the whole next decade or 2 decades of percutaneous revascularization is going to be on focusing on optimal healing. Instead of leaving a cage behind in the vessel, can we do better than that? And this is the evolution of DES technology. This is not going right back to the 1990s, but perhaps 10 years ago. We have the durable polymer stents. We have the first generation, second generation, third generation now, not on this slide. We have the bioabsorbable polymer stents, the fully bioabsorbable scaffold stent, and the polymer-free stents. And it's a nice categorization of the various options we have available. Now, with Health Canada, being Health Canada, we don't have all of these options available in Canada. Our European colleagues have everything available, but we're starting to see some of these options being available for us here in Canada. I'm going to talk about 2 of those options. The first one being the Synergy stent, just because we had a little bit of involvement in its development, and it is probably coming to Canada. This is a stent that has a bioresorbable polymer on it, and essentially it starts off as a drug-eluting stent with everolimus, and it turns into a bare metal stent by about 6 months. It has a very, very thin strut. The key randomized trial that looked at this was the Evolve-2 trial, which was recently published in Circulation, and it was a head-to-head randomized trial of the Promus Element Plus stent versus the Synergy stent, and it was a non-inferiority trial. The primary results are here. It clearly met non-inferiority versus the Promus Element stent for target lesion failure, MI, and TLR. And stent thrombosis overall was a little bit less with the Synergy stent versus the Promus Element stent at 1 year. Now, so that stent is something that I think is coming in Europe. It's now probably the most commonly used stent. In the US, it's emerging very quickly, and it likely will be used in Canada. The whole question, of course, with the Synergy stent is, can you reduce the duration of antiplatelet therapy, and is it safe? And that will be the next trial that will be done, looking at the duration of dual therapy with this stent. The next one was the Leaders-Free trial. This has received a huge amount of attention. This trial was done only in patients who are at high risk of bleeding, and it was using the drug-coated stent, so absolutely no polymer. There's just the stent and the drug. And it looked at patients who were at high risk of bleeding, and it compared it to a bare metal stent. Now, you may wonder about the comparator arm, the bare metal stent, but I'll tell you, even in Canada, even now, a significant amount of bare metal stent is being used. And we get the province of Ontario data coming out every month, and some centers are still using 30–40% bare metal stents. So it's not something that has completely disappeared, and a lot of people think that if you have a patient who is at high risk of bleeding, then put in a bare metal stent and treat with aspirin and clopidogrel for 30 days. So that's essentially what the comparator group in this trial was. And what they found that with only 1 month of dual antiplatelet therapy, that the drug-coated stent was better than the bare metal stent in terms of their primary efficacy endpoint, and also for stent thrombosis, cardiac death, and MI. So the thrombotic endpoints were all lower with the drug-coated stent versus the bare metal stent. Again, this is a BioLemus-coated stent. We don't have it available in Canada yet, but likely it will be coming. But I think the concept is important from a conceptual point of view, that bare metal stents are not without complications. And we look back on the years and we think, oh, well, bare metal stents were a great era. No, they weren't actually. There were a lot of issues that came up, particularly with restenosis, and the stent thrombosis rates within the first 30 days are absolutely the same as drug-eluting stent, including the first generation drug-eluting stents. So then we move to the future, which is now, in terms of biodegradable stents. Biodegradable stents are coming. They're already there in the US. They've been approved by the FDA. In Europe, they're being used. And in Canada, any week now, we're going to have the Absorb stent approved in Canada and available for use. And this is a 10-year conceptual study that was done looking at OCT for a fully biodegradable stent, showing that essentially what we're looking at here is a normal vessel. On OCT, the stent has fully resorbed. There's been no evidence of positive remodeling. It's a smooth endothelium, and there was a side branch that was present here, and that's fully patent. So wouldn't that be the optimal outcome if you had to have a stent today in 10 years to have this type of vessel? And so that really is or was the dream. It's now starting to become a reality, but there are some bumps along the road that I think we need to overcome. So the key study that looked at this was the Absorb 3 trial. It was presented at the TCT last fall, 2,000 patients, half of them randomized to the Absorb stent, the other half randomized to the Xience. It was a 2-to-1 randomization, Absorb to Xience. They looked at vessel diameters of 2.5 millimeters to 3.75 millimeters, and that's important because I'm going to show you the results in smaller vessel sizes versus larger vessel sizes. The lesion lengths generally had to be less than 24 millimeters, and the sizes that were available of the stent were 2.5, 3, and 3.5 millimeters. And you'll see here their primary endpoint. It was a non-inferiority trial. So they met their definition of non-inferiority, 7.8 versus 6.1. No differences in any components of that outcome. But you'll see the event rates obviously are a little bit higher in the Absorb stent versus the Xience stent. And the whole question is, why is that? You'll see thrombosis rates here. None of the individual rates of thrombosis, including the combined definite and probable stent thrombosis rates, were significantly higher, but numerically, certainly they were 1.54 versus 0.74%. And so people have asked, why is that? Is there a cause for concern, or is there something else that's going on? Obviously, the Absorb stent has thicker struts than the Xience stent, probably not quite double the thickness, but certainly about 50% thicker than the Xience stent. And so that may have something to do with the increased numerical rates of stent thrombosis. Now, when they looked at this pre-specified analysis from the Absorb 3 trial, they divided patients into those who had smaller vessels, less than 2.5 millimeter diameter, versus those with a reference vessel diameter more than 2.25. And on the left-hand side, you'll see that's really where the increase in events came from, particularly the thrombotic events. So it's extremely important that vessel sizing be taken into consideration. And also, there's been a fairly steep learning curve with how to put these stents in. You can't just whip it in like you would a regular second-generation drug-eluting stent. There needs to be attention paid to how the stent is placed. And this learning curve, fortunately, because the Europeans have these things in their hands before we do, they've essentially gone through this learning curve already. And there were a flurry of registries at the EuroPCR meeting just a few months ago, looking at how to appropriately put in an Absorb stent. There needs to be careful attention to the lesion preparation, to sizing, and to post-dilatation. Very, very important. You don't need to do an OCT in every single situation, but certainly if you have a small vessel diameter, which you probably should avoid, but if you do put it in a small vessel diameter, that may be a situation where you may want to have a look to ensure that your stent is appropriately sized. And you'll see with the Italian registry, the definite probable stent thrombosis rates have come down to 0.6% at 30 days, and that's completely in line with the stent thrombosis rates that we see when we put in our standard second-generation drug-eluting stents. And the next generation will be coming forward, and the strut thickness you'll see is starting to come down to about 100 microns for the next generation absorbed stent. The one that'll be approved in Canada is called the GT stent, and that's the one that will be on the market here. Now, I want to move on and talk a little bit about STEMI and thrombus formation. You'll see here, this is a case where a patient came in with essentially cardiogenic shock. They had elevation and lead AVR and ST depression and all of their other leads. We brought them up to the cath lab, and this was their initial angiogram with thrombus in the left main extending into both the LAD and the circumflex, and essentially no flow beyond that. So this is a situation that we would handle very differently today than we would have, let's say, 10 years ago. People talk, we have a heart team here, but I can tell you at 3 o'clock in the morning, consulting with your heart team, by the time you finished your page to the surgeon, the patient would be dead. So this is a situation where you need to act quickly and get the artery open as soon as possible. So in this particular situation, we just went for it. Both of the vessels were wired. There was a little bit of flow, but you'll see the extensive clot extending into both vessels. I know that we were the coordinating center of the total trial, but we did thrombectomy here. I'm not sure it made any difference, but it made us feel better. And you'll see here we stented directly into the to the left main into the LAD, and we ended up with a fairly good result here, and TIMI3 flow fortunately was restored. But there's something on this last picture that you'll see, and that's an intra-aortic balloon pump. And the one thing, all of the discussion about mechanical support is important, but I can virtually guarantee you that this patient never would have made it into the shock trial. I promise you that. There would have been no time to randomize the patient. The patient would have been dead by the time you finished your randomization telephone call. And so I'm not so sure I believe that an intra-aortic balloon pump is completely useless. I still think there is a role for that balloon pump. It's relatively cheap, and I can tell you we do 1,000 STEMIs a year where I practice, and we use balloon pumps if we need them. We don't shy away from Impella devices, but we don't reach for them as our first device, particularly in this real-life situation. On that note, there are a number of things. I'm not going to belabor this point because others have talked about it. There is the intra-aortic balloon pump, the Impella device. The main limitation for the Impella is probably none of the things I heard this morning. It's the number one limitation is cost right now. We are capped by the number of Impella devices that we can put in our center. It is tracked very carefully. But like most things that are expensive, over time the cost eventually comes down and they become more widespread. The PROTECT 2 was the main trial that looked at the Impella device versus intra-aortic balloon pump. Their primary endpoint was at 30 days, and then composite follow-up at 90 days. This is an extraordinarily difficult type of study to do and a very expensive study to do. The results themselves are shown here. Very promising. The intention to treat analysis did not show a significant benefit of the Impella over the intra-aortic balloon pump, but certainly numerically, the event rates for MACE were lower with the Impella than with the balloon pump. And then they did a secondary per protocol analysis, and in that per protocol analysis where they only included patients who met the inclusion-exclusion criteria, there seemed to be a benefit at 90 days on major adverse outcome events. I'm not sure we're going to see this trial repeated again, just because of the cost of doing such a study. But it probably should be repeated. And then this is Hung Lee referred to this really nice paper in JACC JACC Interventions, I believe, earlier this month or last month, looking at who should receive these devices and what types of patients. And if you follow this through, it's actually a very, very reasonable approach to using mechanical support. And a very wise way of proceeding, I think. I'm not going to go through this in detail. So let's move on to some other issues in percutaneous revascularization. And I think the greatest limitation right now of primary PCI, other than improving our systems of getting access for patients in a timely fashion, which is a whole different discussion, the biggest limitation right now for STEMI, no question, is improving microvascular perfusion. You and I are very good at stenting the vessel. We're able to get epicardial perfusion extremely well, but the one thing that interventional cardiologists are helpless with is microvascular perfusion. The myocardium doesn't see all of the great work that you've done. And we've had a few therapies that have been evaluated: thrombectomy, deferred stenting, and some new things that are coming up. So the total trial, this is the result for thrombectomy. This is an all-comers. It doesn't mean that you abandon thrombectomy completely. Keep it on the shelf. Use it in cases where you think it's necessary. Patients that may not have been enrolled in the total trial, I still think there is a role for it despite the results. But I certainly wouldn't use it the way we did before in every STEMI that rolls through the door. And then deferred stenting, which is a very hot topic, at least here in Montreal. They're doing a very important trial. That some earlier studies had suggested that if you delay putting your stent in for a few days, you may be able to avoid this no reflow phenomenon, and you may improve microvascular perfusion. And it makes sense. I mean, all of us have done primary PCIs. You do your initial balloon angioplasty, you restore TIMI3 flow, you put your stent in, and all of a sudden you have no reflow. So it's not an unreasonable concept. But the DYNAMI 3 trial was just done, a good-sized trial, 1,200 patients, initial stenting versus deferred stenting. They didn't see any significant difference of the deferred stenting strategy. And the final word is not out yet. The final word will be out after this trial is done, the primacy study. Marc Jolicoeur is leading this important trial. And before we make our final decision on this, I think we need to see the results of this trial. And we need to continue to support this trial. It's a very, very important CIHR-funded trial. And there will be another trial starting soon in Canada, the STRIVE trial, which we're leading with a number of other Canadian sites. Philippe Genereux is involved and others. The STRIVE study, which we're looking at adjunctive low-dose intracoronary TPA as an adjunct to primary PCI. And here we're talking about giving, so remember it's about 100 milligrams is the standard dose of TPA. Here we're looking at giving intracoronary doses of 6 milligrams or 12 milligrams. So even if you give an intracoronary dose of 12 milligrams of TPA, although it's 12% of the systemic dose, you're still getting about 10-fold the concentration within the microcirculation of the TPA. And by the time it leaves the coronary sinus and exits the coronary circulation, you're left with negligible amounts of TPA activity within the systemic circulation. So this is a way of getting the benefits of lytic without experiencing the bleeding complications that are associated with the lytic. And believe it or not, it really hasn't been properly tested. There was a small trial with streptokinase published in the New England Journal a few years ago, which suggested a benefit, but obviously that didn't go very far, and we need further studies to see. And so we're not going to a big phase 3 trial. We're doing a 600-patient trial. Let's see if there's a proof of concept, and then we can move from there. But we can't leave this issue alone. This is the single biggest problem that we have right now in primary PCI, and this is what's going to advance the field forward and get better results for us and our patients. Now let's move on to multi-vessel disease. There's lots of discussion about this, multi-vessel disease in patients with STEMI. The one thing I will say, if there's one thing you should take away, is that we know that PCI is good for patients with angina. And this discussion of multi-vessel disease shouldn't really involve those patients. If they have angina or they have symptoms, they should receive a stent. But that's not the question that I think is most paramount. The question is, if you do a prophylactic stent, if you put a stent in, if you put a preventive stent in the patient, will that prevent a death or MI down the road? Any one of us in this room, if a patient comes and says, "Doc, I'm having chest pain every time I want to do something," you bring them in, you do an angiogram, you stent the non-culprit vessel, big deal. We do that every day. So it shouldn't surprise anybody that PCI is better for that outcome. But what we don't know is if you can prevent somebody from having a death or prevent an MI down the road, boy, that would completely change things for what we do as interventional cardiologists. Now we're starting to challenge things such as statins and medical management. Let me show you a case, because I think a lot of people think they have this issue figured out. I can tell you I'm completely confused. I think this is an extremely complex disease we're talking about, and we really know very little about it. We're starting to get a better understanding of coronary disease, but we don't know a lot about it. This is a patient who came in with an inferior STEMI a few years ago, RCA occlusion. They had their RCA stented with good angiographic results. The patient also had non-culprit lesion disease. They had a tight proximal LAD lesion and a moderate lesion in the circumflex. Now, the patient was treated medically and in fact did extremely well until last week when I was on call and the patient came back in with another STEMI. And we were almost certain when we looked at the old angiogram that the culprit would be that proximal LAD, but in fact the culprit wasn't the proximal LAD, it was the circumflex. And are we gonna see that? We're not gonna see the circumflex move. If you could click on it, if somebody's up there, just click on the film on the left-hand side. Let's see if I can go back one there. There, that one. Just click on the left-hand side. There. So that 50% circumflex ruptured and caused the recurrent STEMI. But the proximal LAD, which everyone is asking me about, incomplete. How many proximal LADs do you have? How tight are the proximal LAD lesions? Guess what, folks? Those aren't the lesions that rupture. The ones that rupture, it's all about the biology. This, if you had done an FFR, would have been completely negative. You would have treated this medically. The patient would have gone home. You would have told the patient, "You're fine. You don't need a stent in that artery. Don't worry about it." But we have put a stent in the one with the tight blockage in the proximal LAD. So don't worry, you're fine. You know, is that really the truth? I'm not sure. I think there's a lot we don't know about this disease. There's the right coronary non-culprit. So this patient went ahead and had their circumflex stented, flow restored to the vessel. And if you look at the FFR for the proximal LAD, it was actually significant FFR in the proximal LAD. The FFR was significant. It probably would have been significant several years ago as well because it was completely unchanged. But then when we did an OCT, we saw the significant lesion in the proximal LAD. But what else did we see? Or what else did we not see? We actually didn't see any lipid in the vessel. This was not a high-risk plaque. The plaque had absolutely no lipid. This plaque likely will never rupture or cause an MI. And the patient was going about their normal activities without any angina, so the question comes up then, why in the world would you stent it? So all I'm trying to do here is I'm just trying to be a little provocative by saying sometimes we think we know what we're doing, but I don't think we do, and we have a lot more work to do. Fortunately, in the complete trial, we have an OCT sub-study where we're doing this serially in many non-culprit lesions, and we'll be correlating it with clinical events to see what we should be doing. What should we be stenting? What should we be leaving alone? Maybe it's a combination of the anatomy or the physiology with the biology. Maybe we need to bridge those two things together in some way that we don't yet understand. But I don't think we have the answer yet. Even though there have been a lot of trials. These are all the trials that have been done of routine stenting versus medical management. And this was the most recent one that was done, the DYNAMI-3 trial, which is very typical. This is an FFR-guided approach. And you'll see in the trial, there's absolutely no difference in death or MI. Hazard ratio for death was slightly higher with complete than the medically managed 1.4. Non-fatal MI, absolutely no difference. And of course, there's a difference in revascularization, which, as I said before, is an expected finding. If somebody needs to have it done because they're having angina or they're having problems, then you go ahead and do it, and you can do it safely, and we do that every day, and there's usually not an issue. But the other 83% of patients that you routinely do that prophylactic stent in to prevent something that may or may not occur, that's the question that we're talking about. And that's the question that needs to be answered. And this is the reason why the guideline committees have been so careful with changing the guidelines based on the small trials. This is an analysis that's coming out, I think this month, that Kevin Bainey did. And it was a trial sequential analysis published in the Canadian Journal of Cardiology. It looked at death and MI, and essentially what he showed was actually a marginally significant benefit of complete revascularization. You'll see the hazard ratio above favors complete revascularization, barely. But on the bottom, you look at a trial sequential analysis, and you'll see the red line there is essentially, this red line over here is looking at 2 standard deviations, which is called a Z curve. So if you're above 2 standard deviations, you get a p-value of 0.05. So, but if you look at a trial sequential boundary, let's say this was a clinical trial you were doing and you wanted to be confident that was a real result, this is the level of evidence that you would require. And there's still a very, very big gap in that level of evidence. And you know, in the complete trial, we've now reached 3,000 patients in the trial, and they seem to be high-risk patients that we're getting in, according to the angiographic core lab, and the DSMB keeps telling us to go ahead. And the trial now is recruiting all over the world. It's got about half the patients from North America, Canada, and the US, and then the other half of patients in Europe, and then we have some patients from Australia, South America, and some other places contributing. And you'll see the recruitment curve here, and I don't know what's going on, but in the beginning we had trouble convincing people to do the trial, and now you'll see the recruitment curve is going so well that we've gone off our axis and we're actually going to finish ahead of time. So people are really enthusiastic about the study. We had our best month last month that we've ever had in this trial. And we will finish this calendar year recruitment, and we'll have follow-up. We don't know how long we're going to have follow-up for afterwards. Likely it'll be a minimum of a year, but maybe 2 years depending on what the event rate is. And you'll see here all the investigators and the huge number of patients that people are putting in all across Canada. You know, Vancouver, 70 patients, Alberta, 66 patients, South Lake has put in 53 patients, London has put in 59 patients, and so on. So huge numbers of patients that people are putting into the trial. And you know, this just shows what we can do as a country when we believe in a question and when people really want to contribute. This is really what we can do in Canada. So congratulations to all of the investigators, and thank you to everyone for their support.